Bismillahirrahmanirrahim. We are discussing the ovarian tumors, and in my previous lecture we discussed the epithelial derived ovarian tumors. Today we will discuss the germ cell ovarian tumors. In my previous lecture I told you a formula of three sentences, and we can use these three sentences to remember the names of the various ovarian tumors. Now today we will use the second sentence, and that is the doctor examined the cancer. So Dr. D, this is dysgerminoma. E, endodermal sinus yolk sac tumors. T, teratomas. And C, for choriocarcinoma. The germ cell tumors arise from the pluripotent germ cells that are supposed to differentiate later in life into either sperms or the oocytes. Now, the germ cell tumors arising from the pluripotent germ cells that will give rise to the sperm or oocyte later on. These tumors can be malignant or they can be benign. Now you know that the three germ layers they develop from the embryoblast are the ectoderm, mesoderm and endoderm. The ectoderm cells will give rise, for example, some ectodermal germ cells differentiate into the cells of the brain and spinal cord, and some mesodermal germ cells they will form the bones and muscles, and some endodermal germ cells they will form the gastrointestinal tract. So the whole body tissues are derived from these three germ cells, for three germ cell layers. Now there are certain germ cells that do not differentiate and remain as germ cells. They remain quiescent, and it will be later in life that these quiescent pluripotent precursor cells will develop into the oocyte in the female and sperm in the male. They are pluripotent cells and they have the capability to differentiate into either the sperm or the oocyte. Now what happens in germ cell tumors? These precursor cells they continue to proliferate and divide uncontrollably, or we can say neoplastically, and they will give rise to the germ cell ovarian tumors. Now the germ cell ovarian tumors, as I told you, we can remember their names by the sentence the doctor examined the cancer. The D is for dysgerminoma, the E for endodermal sinus yolk sac tumor, which is the most common tumor in the children. T, teratoma. Teratomas are tumors that may contain cells from any of the three germ layer cells, and they are also known as the monster teratomas. Choriocarcinoma, which is derived from the C in the cancer, it arises from the sensatiotropoblast. If you remember your embryology, the embryo divides into embryoblast and trophoblast, and the trophoblast then divides into cytotrophoblast and sensatiotropoblast, and this is the sensatiotropoblast which will develop into the placenta, and tumors arising from this sensatiotropoblast are called as the choriocarcinoma. Now first coming to the first type of tumor, the teratoma. Better tera means monster, and they are called monster tumor because they contain all different types of tissue, and therefore these tumors may contain bone, sometimes they may contain teeth, they may contain hair, eyes and neurons. The teratomas are divided into mature cystic teratoma, which are benign tumors, and immature cystic teratoma, which are often malignant. So as I told you that the teratoma can arise from any of the three germ layers, the ectoderm, endoderm, and mesoderm. For example, the in teratoma we may see stroma ovari, and the stroma ovari is the tumor which contains thyroid tissue. And as you know that the thyroid tissue will produce thyroid hormones T3 and T4, and in the presence of these tumors, stroma ovari, a person can develop hyperthyroidism. Now, coming to the immature cystic teratoma, they arise from the ectoderm, from the neuroectodermal cells, right? And these tumors, they are very aggressive, and most often they are malignant and easily metastasize to other organs. Now, teratomas may be benign or it may be malignant. As you know that the benign tumor, it will not invade the local tissues, it will not invade local extension, and also it will not undergo metastasis or to spread to other parts of the body. And these mature cystic teratomas are the most common ovarian tumors in the younger women, and since it contains elements from all the three germ layers, the ectoderm, endoderm, mesoderm, so it may contain various body parts, and therefore these are also known as the monster tumors. Now, malignant tumors, malignant teratoma are the immature teratoma, and when we say malignant tumor, we mean that it can invade the local tissue and it can spread through metastasis, and under the microscope the malignant tissues have no clearly defined borders and less organized nuclei, by what we mean that the nucleus may show hyperchromatosis, there will be abnormal nuclear cytoplasmic ratio, and mitotic figures will be visible. So these malignant tumors in the form of immature teratoma, they arise from part of the ectoderm known as the neuroectoderm cells, and most often they are malignant, aggressive, and shows early metastasis. Now, coming to the York-shaped tumors, the York-shaped tumor or endodermal sinus tumors are those tumors that will arise from the precursor cells, and these precursor cells supposed to develop into the yolk sac. The yolk sac, as you know, it provides nutrition to the embryo, and later on most of the yolk sac is incorporated into the gastrointestinal tract, but the germ cells, the precursor cells that are supposed to develop into the yolk sac, if these cells start uncontrolled neoplastic proliferation, they will give rise to the yolk sac tumors or endodermal sinus tumors. The yolk sac tumors or endodermal sinus tumors are the most common germ tumors in children, and one of the characteristics of the yolk sac tumors that can be seen under the microscope is known as the scalar devolved bodies. And what are scalar devolved bodies? Actually, under the microscope they can be seen as rings of cells around the central blood vessels, as is clear from this picture. Now, choriocarcinoma will arise from the sensatiotropoblast cells. During the early embryonic development, when the embryo starts development, it is differentiated into embryoblast, which will form the fetus, and the trophoblast, which will form the supporting tissues, and the trophoblast is divided into cytotrophoblast and sensatotrophoblast, and it is the sensatotrophoblast cells that will form the fetal part of the placenta. Placenta is formed by fetal part and by maternal part. So the sensatotrophoblast cells, they will form the fetal part of the placenta, and since it contains lot of blood vessels, these tumors, they bleed very easily and spread, and mostly these tumors are small. Since these tumors like placenta produce lot amounts of beta human chorionic gonadotropin, they will form cyst, fluid filled sacs in the ovary, known as the ovarian cysts. Now the dysgerminoma is the tumor which will arise from the precursor cells that will normally develop into the oocyte, and if these cells start proliferating uncontrollably, they will give rise to the tumor known as the dysgerminoma. The dysgerminoma is the most common malignant ovarian tumor, and it consists of cells with central nuclei and surrounded by clear cytoplasm. Now, why ovarian tumors develop? As you know that we don't know the exact cause of any tumor, but some risk factors are there. First of all, we go to discuss the normal ovulation process that occurs during the menstrual cycle, and ovulation that mostly occurs around the day 14 at the end of the follicular phase of the menstrual cycle. So when the Graafian follicle ruptures and releases an ova, what happens that the follicular cells, they are damaged. When they rupture, they will get damaged. Later on, the healing processes starts to heal these ruptured follicles, and there is the there are cell divisions and which are necessary for healing the ruptured follicles. And as you know that the cell division itself provides a risk for mutations. So if there are so many ovulatory cycles in a female, there are more chances of cellular divisions and more chances of mutations. And if the genes becomes mutated during cell proliferation, they can give rise to the tumor formation. So from this conclusion, we can say that throughout the reproductive life of a female, if we count the total number of ovulations that occur in a female, so a female with increased number of ovulations, increased number of the rupture of the Graafian follicles, increased number of the healing processes and cellular divisions, will have increased chances of genetic mutations, and this provides an increased risk for the formation of ovarian tumors. In comparison, a woman, for example, if the total number of ovulations during the life of a woman, if they are comparatively less, and what are the conditions when there will be less number of ovulations? A woman that becomes pregnant. Once a woman becomes pregnant, the menstrual cycle stops, the woman goes into amenorrhea, and there is no further development of the Graafian follicles, no ovulation, no rupture of the Graafian follicle, and overall this will decrease the total number of ovulations in the life of married persons who undergo pregnancies to the one that is suppose unmarried, and the one who doesn't become pregnant. Similarly, you know that during breastfeeding, when the mother is feeding the baby, during this period the patient has gestational amenorrhea, and during gestational amenorrhea there are no menses, there is no development of the ovarian follicles, no rupture, no ovulation, and decreased number of ovulations. The third point is that a female who is using oral contraceptives, they also inhibit ovulation. And so the cumulative effect of pregnancy, breastfeeding, oral contraceptives, it will decrease the number of total ovulations that occur in such a female as compared to the other one. So decreased number of ovulations decreases the risk of ovarian tumors. On the other hand, increased number of ovulations and increased number of cellular divisions for the repair of the ruptured follicles uh, will increase the risk for the ovarian tumors. The increased risk for ovarian tumor is also associated with endometriosis, in which the endometrial tissue, which is normally confined to the uterine endometrium, but if the endometrial tissue develops somewhere outside the uterus, for example in the ovaries, in the fallopian tubes, this is known as endometriosis. And the other disease known as the polycystic ovarian syndrome, in which multiple follicles develop in the ovaries, and which is a genetically determined disease, mostly with unovulatory cycles and problems like hirsutism, acne, and production of the male sex hormones, androstenedione and testosterone type male hormones. So these conditions increase the risk for the ovarian tumors. The genetic background of the ovarian tumors, round about the all ovarian tumors, there are two genes. One is known as BRCA1 and the other is known as BRCA2. And mutations in BRCA1 and BRCA2 increases not only the risk of ovarian tumors, but also the risk of breast cancer. These mutations are inherited in autosomal dominant pattern. There is another condition known as the hereditary non-polyposis colorectal cancer, also known as the Lynch syndrome. And in the Lynch syndrome, the risk for many tumors is increased, including the ovarian tumors. Now coming to the symptoms of the ovarian tumors, they may be subtle and non-specific. There are individual variations. One individual may suffer from increase or decrease intensity of one type of sign and symptoms, and the other from another. But generally speaking, the symptoms include abdominal distension, bloating, and lower abdominal or pelvic pain. And if the ovary is twisted, for example in ovarian torsion, it will give rise to severe pain. And sometimes the patient develop ascites fluid in the peritoneal cavity, and when we examine the patient, sometimes we can see abdominal masses, and potentially they can give rise to the bowel obstruction. And another important symptom is the dyspareunia, which is the pain that the female experience during intercourse. A special point here that I want to mention is the development of the sister Mary Joseph nodules, and this will occur and can be seen when the tumors, when an ovarian tumor metastasizes to the umbilicus. And this can happen with almost all ovarian tumors, the sister Mary Joseph nodule. Now, how we diagnose ovarian tumors? History, physical examination, menstrual history, and percutaneous ultrasound and transvaginal ultrasound. But the exact diagnosis that we make is from the biopsy. Here, when we remove a small tissue from the tumor and examine it under the microscope, the histopathologist tells us that the tumor is benign or malignant. if the tumor cells show hyperchromatosis, if there is abnormal cytoplasmic nuclear ratio, if there are mitotic figures, if the nuclei are misshaped, these are characteristics of the malignant tumors. And as compared to the percutaneous ultrasound, transvaginal ultrasound is more informative. In transvaginal ultrasound, an ultrasound probe is inserted into the vagina and we can see the pelvic organs more clear and better than percutaneous ultrasound. Now, there are certain tumor markers like beta human chorionic gonadotropin, particularly if we say the uh, tumors that secrete beta human chorionic gonadotropin like choriocarcinoma. So, by examining the levels of the beta human chorionic gonadotropin can help us in the diagnosis. We will do CT, computer tomography, or magnetic resonance imaging to see the size, location, and position of the tumor in the pelvic or abdomen. So, coming to the treatment of the ovarian tumors, if the tumor is confined to the ovary, if it is lying in the ovary, then surgical removal of the ovary will solve the problem. But this depends on the time of diagnosis, that when we diagnose it. Unfortunately, if the tumor has spread to other parts of the body, then surgery will be of no use, and then we will proceed towards the chemotherapy and radiotherapy. An important point here is the carbohydrate antigen 125, and this carbohydrate antigen 125 is produced by the ovarian tumors, and during the therapy, and to find out the success of our therapy, we will detect the levels of the carbohydrate antigen 125, and increased levels will show us that the tumor is progressive or recurrence has occurred, while the decreasing level will show us that the therapy is going in the right appropriate way. To summarize the germ cell ovarian tumors, we can say that they arise from the precursor pluripotent germ cells. There are 4 cells: teratoma, which may be mature cystic teratoma, which is not so much serious and affects the younger women, and in comparison, the immature cystic teratoma, it is severe, aggressive, and easily metastasized. It is malignant tumor. The second tumor, the endodermal sinus tumor or yolk sac tumor, will arise from the precursor cells that will give rise to the yolk sac, which provides nutrition to the embryo. The choriocarcinoma, it will arise from the sensitiotropoblast cells, which will form placenta, and therefore these tumors, since they contain lot of blood vessels, they easily bleed. The dysgerminoma will arise from the germ cells that will develop later into the oocytes, and therefore these tumors are derived from the pluripotent cells that in later life develop into the oocytes. The increased risk is associated with increased time in ovulation. If we count the total number of ovulations that a female undergoes during his reproductive life, if they are more than in a woman as compared to another woman who becomes pregnant, remains with amenorrhea during pregnancy, no ovulations, if she is breastfeeding and there is gestational amenorrhea, during which no ovulations occur. If she is using oral contraceptives, that also inhibit ovulations. So by collecting all these things, the total ovulations in this female are less as compared to the one with increased time in ovulations. And here in this situation, in one female with more times in ovulation and more number of ovulations, the risk is increased, and the one with less number of ovulation that are mostly due to pregnancy, breastfeeding, oral contraceptive, the risk is decreased. Moreover, the mutations in the BRCA1 and BRCA2 genes that are also involved in increasing the risk of breast cancer, they are also involved in the important increased risk for the ovarian tumors. And the hereditary non-polyposis colorectal syndrome, known also as the Lynch syndrome, which is associated with many other tumors, also include ovarian tumors. Now, we come to the summary that the ovarian tumors arise from the epithelial that we discussed in our previous lecture, sex stromal tumors, and germ cell tumors that we discussed today. The germ cell tumors differentiate towards oogonia, primitive embryonal tissue like the yolk sac, and which give rise to the endodermal sinal tumors, and the placental tissue syncytiotropoblast, which will develop into the tumor choriocarcinoma, and the teratoma, which will contain elements from all the three germ layers, and they are also known as the monster teratomas.